Hi everyone, and welcome. I'd like to give a warm welcome to our special guest, Associate Professor Martin Batstone. Martin, is that all right if I call you Martin?
Please do.
Okay, so Martin is the Director of the Royal Brisbane and Women's Hospital Maxillofacial Unit. Martin is also a member of the Queensland Regional Surgical Committee and ex-president of the Australian and New Zealand Head and Neck Cancer Society. So you'll be familiar with some of our fantastic surgeons that we've got in New Zealand.
Absolutely.
Of which I had one, Nick. I think you probably know Nick very well. I think he's currently the president of the Head and Neck Cancer Society in New Zealand. So Martin completed his medical and dental degrees in the University of Queensland, and as a graduate of the Queensland Oral and Maxillofacial Surgery Training Programme. And Martin has completed 3 additional years training in the head and neck cancer surgery in Liverpool in the UK. So you'll be quite familiar with the frosty weather of the UK. And Liverpool, don't they have great accents?
Yes.
You probably need an interpreter for that time, actually, just to understand what they were saying, probably. Joining the fellowship of the Royal College of Surgeons of England. And Martin also practices the whole scope of oral and maxillofacial surgery with a special interest in head and neck cancer and reconstructive surgery. You've also, which is fascinating, have a master's in philosophy.
Yeah, I do, but that a master's not in philosophy, it's a research degree.
Right, a master of philosophy. And in your free time, I understand you're a keen cyclist and a windsurfer.
That's correct.
Well, you're probably living in the best part of the world for those 2 things.
Yes. Yep.
Welcome.
Thanks very much. Thank you, everyone, for spending your evening with me. I'm talking about, I guess, what are my interests in the management of head and neck cancer specifically. I apologize for my voice. I don't normally sound like this. I don't have COVID, I'm pretty sure, but I do have a 1 and a 3-year-old, so I have a frequent stream of upper respiratory tract infections. I hope my voice doesn't give out, and I think I'm clear enough. So we're going to talk about oral cancer, a bit about reconstructive head and neck surgery, and a bit about facial prosthetics. We'll start with oral cancer, and really what we're mostly talking about is squamous cell carcinoma. That's the commonest type of oral cancer. It makes up about 90% of oral cancers. Obviously, there are a smaller proportion of other malignancies, such as salivary gland malignancies, sarcomas, melanoma, metastases, lymphoma, but the vast majority are SCC. This is a graph from Queensland, actually, from the Queensland Cancer Analysis team, but I'm sure the data, although the numbers are different, will be very similar to what's going on in New Zealand, because we have relatively similar populations. And if you look at this graph, you can see that head and neck cancer is becoming more common. The reasons it's becoming more common, though, is not actually because there's an increasing rate in individuals, but because of 2 things. One is that there's more people living here, and the other is that the population is getting older, and head and neck cancer in general, like not all, but most cancers, is a disease of aging. So as you get older, you're more likely to get a cancer, or in fact, any cancer. So the reason that head and neck cancer is going up in Queensland is because of mainly 2 factors: population growth and aging. But there are some types of head and neck cancer that are actually increasing in incidence per se, which means your risk of getting them is going up too. And if we look at this graph, it tells you why that is. So there's really one outlier amongst these, which is the orange line. And that's oropharyngeal cancer, or cancer of the tonsil, the base of your tongue, the soft palate. And that's really primarily due to, I guess, what we call an epidemic in HPV, or human papillomavirus. So I'm sure you're all familiar with that virus. It's ubiquitous. There's about 100 types of HPV. Not all of them cause cancer. A lot of them cause warts on your fingers, warts on your toes. there's a lot that you can get in your mouth that are non-carcinogenic, but there's probably 10 or 15 types that are carcinogenic, which is really driving that rising rate of oropharyngeal cancer. And the other ones are generally trending downwards because smoking is becoming much less common, and smoking and alcohol really are the primary causes of standard oral cancer and particularly laryngeal cancer. So a bit of a mixed picture. Rise in the rate of some types of head and neck cancer, oropharynx especially, probably general gradual decline for age standardized incidence, but an increase in overall number because our populations are getting larger and our populations are getting older. So what is the etiology of oral cavity cancer? So oral cavity cancer, just to differentiate it, is cancer in your mouth, lips, tongue, your cheek, your palate, lower gum, upper gum, but not your tonsil, soft palate. That's oropharynx. Generally, smoking and alcohol, though, they're becoming less and less common. I think the incidence of smoking in Australia now is 13%, which is one of the lowest rates in the developed world, actually. Betel nut use means that oral cancer is actually the most common cancer in some countries, specifically India. It's more common than bowel cancer and breast cancer. It's the most common cancer, which amazes people. There are some rare genetic conditions that make you more predisposed to oral cavity cancer. And age predisposes you to cancer. The reason for that is just maths. You know, every time your cell turns over, there's a chance of it making a mistake. Your body is full of cells. A lot of them will turn over regularly. And as you can imagine, the more years you've lived, the more times those cells have turned over, the more chance one of them's made a mistake, and then that mistake has stuck, you know, so the cell hasn't just died, it's stuck, continue to replicate and grow, and that's how you get a cancer. So you can imagine that the more times you roll a dice, the more times it's going to come up with that number. And obviously this is a million-sided dice, but if you roll it a million times, then every now and then it's going to come up one, which is the reason that cancer in general is age-related. And a lot of people, it's bad luck. I see quite a lot of patients in their 70s, 80s, and 90s with oral cavity SCC who've never done a naughty thing in their life, never smoked, never drunk, and they say, "Why have I got this?" And the honest answer is, you've lived a long time, which probably doesn't help you, but it's just the truth. And there's probably other things that cause oral cavity cancer that we don't know about. Virus Y, for example. Many of you will have heard about what we'd consider almost an epidemic of oral cavity cancer in young women. It's not really an epidemic, but there's certainly 18, 25-year-old women developing tongue cancer, and we really have no idea why that's occurring. So there's probably some other etiologic factors that we're not aware of that are floating around in the community causing this problem. HPV in general, or the wart virus, does not cause cancer in your mouth. It really only starts at your tonsils and your tongue base, and it's probably a bit beyond the scope of this talk as to why, but it's got to do with the cell type, which is the same reason it affects the cervix in women. So why me? Age, some form of genetic predisposition, mouth rinse, although you've probably noticed now that you can't buy mouth rinse with alcohol in it anymore, or the companies have removed it. And I don't know if Listerine is a popular mouth rinse in New Zealand, but yeah, see a few people nodding, but you'll be interested to know that Listerine really struggled to remove alcohol from their formulation because it relies on a lot of oils, and it's very hard to, for the flavor, it's very hard to dissolve oil in anything other than alcohol. So I think they really struggled to actually make an alcohol-free version of Listerine. And as I said before, virus Y or some other environmental factor. So what about treatment? In general, the treatment for oral cavity or mouth cancer is for patients who are well enough and elect for curative intent surgery. It really is, surgery is the mainstay of treatment. There's a couple of reasons for that. One is it's more effective than radiotherapy or chemotherapy alone. And the second is that the side effects of radiotherapy in your mouth in particular can be quite significant. Radiotherapy we would use in general for about 40% of patients, and that's usually if you have more advanced malignancy. So surgery for 100%, 40% of people will get radiotherapy, and chemotherapy ends up getting given to probably about 10% of patients. And really, only those who have the most advanced form of cancer. So I liken it to a 3-barrel shotgun, if that makes any sense. So if you have an early stage cancer, you can get 1 barrel, more advanced 2, really advanced 3. And you can imagine that as you apply more treatment to a person, to their malignancy, the chance of causing them a side effect from that treatment goes up significantly as well. So what about some research? This has been undertaken by one of my PhD students, Tim Liu, and we were interested in the impact of surgeon volume on survival. And we were talking about this a little bit before the meeting started. So there's been lots of interest in surgery over the years, and people have focused on the patient, the tumor. You can see the pathologist hanging around underneath the table, waiting for a specimen to work out exactly what's going on. So looking at the cancer specifically to work out how that might impact survival. But we were interested in the people standing above the patient. What does their role or skill mix or impact actually have on survival? Volume outcome associations are not new. So if you are treated by a high volume cardiac surgeon, you have a better, in a high volume hospital, you have a better chance of doing well. The same for thyroid surgery, colorectal surgery, ovarian cancer, pancreatic cancer, and the list goes on and on and on. But not really particularly well looked at in head and neck cancer and oral cavity cancer specifically. And this might not shock you, or maybe it will shock you, but basically, if you are treated by I think there was about 800 patients in this study and probably 15 surgeons. If you were treated by a high volume surgeon, your chance of being cured was effectively 33% higher than if you were treated by a lower volume surgeon. And high volume means at least 20 cases a year. I don't know how familiar you are with statistics. The table on the right-hand side of your screen basically shows that all the other factors that make you do worse. So if you have a higher T stage or higher end stage, you would expect a lower chance of survival. That's quite normal. But a high volume surgeon made a massive difference to your chance of actually being cured of your disease. And there are lots of reasons why that is the case. And it's not just because they hold the knife better. It's about the team that surrounds those people. It's about the pathology. It's about your aftercare in the ward. It's about how you're looked after. It's about a rational approach to using adjuvant treatment like radiotherapy and chemotherapy. It's not just about the operation. But being treated by a high volume clinician in a high volume institution is a very good way to improve your chance of being cured. And the problem with that for a place like Australia and New Zealand is that we have a geographically dispersed population, low population volumes in some areas, and this is a rare disease, not for your group, but for society, it is a rare disease. You can't have a high volume head and neck surgeon in Invercargill. It's not possible because there's just not enough people to have the incidence of disease to generate the kind of amount of work that would keep them at that skill level. Many of you will be familiar with immunotherapy. I'm sure you've heard of immunotherapy, and I'm not bagging immunotherapy by any stretch of the imagination. I've certainly seen some miracles with immunotherapy, but this is the difference between immunotherapy and normal care. And don't ignore where the positions are on the graph, but your improvement is 20% with immunotherapy and 33% with high volume surgery. And probably the most shocking thing about this is actually the cost, because high volume surgery is cheaper because you have a lower complication rate. Patients tend to stay in hospital for shorter periods of time. There's less need for reoperation. And I have a table a bit later on in this study which will show you how expensive immunotherapy is, and you probably already know that yourselves if you've been advocating for its use in head and neck cancer. The other thing that Tim looked at as part of his PhD, which might be interesting to people, is using radiotherapy in what we call intermediate risk oral cavity SCC. So probably the best way to define this is to try and help people make decisions for themselves. So many of you, I suspect, will have been discussed at a head and neck clinic, and then someone will have given you a recommendation, said you should have X, Y, or Z as part of your treatment. And I don't know, but I suspect not a lot of, if you do this, your chance is X. If you do that, your chance is Y. Those kind of conversations don't happen as much for us as they should, partly because this is a rare cancer. But for things like breast cancer, for example, those conversations and risk calculators are much more prevalent, partly because the disease is more common. So there's a greater bulk of information from which you can draw reasonable conclusions. And probably the best way to illustrate what we're trying to do is give you an example. You don't need to remember the numbers, but if you have a tongue cancer, 2 centimeters big, this is how thick it is. It's cut out. There's no involved margins. If you don't have radiotherapy, your chance of being cured is 70%. If you do have radiotherapy, your chance of cure is 85%. And the purpose of this study is not to stop people having radiotherapy. It's to let people make an informed decision, as with the information that's as close as possible as we can get to you. So therefore, you can do the maths yourselves. If you give radiotherapy to 100 people, 70 will get radiotherapy, but they don't actually have cancer. So that's harmed them, unequivocally, because you're getting the side effects without any benefit. 15 people will benefit because they would otherwise succumb to their malignancy, but with radiotherapy, they'll be cured. And 15 will die anyway. So in effect, the radiotherapy has also been useless, hasn't it? Because it may have prolonged their life, but it hasn't cured them. So really the purpose of this is not say radiotherapy is bad, because everyone's going to have an individual decision to make, and I've tried to give this information to patients as best I can in the past. And I'm always surprised at how different people's decisions are. And that's good, because the purpose of it is autonomy, isn't it? It's making a decision for yourself that is relevant to you. So I had a young man, and I look at him and I think, oh, I wouldn't have radiotherapy if I was you. And he says, I just need to survive for my family, for my children. And I couldn't look at myself in the mirror if I didn't do everything that I could. And I'm like, okay, fair enough. That's your decision, good reasons, and that, I guess that's the purpose of this, is not to say don't do it or do it. It's to say, this is what we know of your risk is, this is what we think your chance of being cured now is. Would you like to decide? And this really applies to a very big gray zone in the middle of oral cancer. Very small early cancers, no one argues about it too much. The risk of radiotherapy outweighs the benefit. Very advanced cancers, no one argues about it too much. You need to have radiotherapy, you've got advanced disease. But there is a big gray zone in the middle where we're trying to let people make their decisions themselves. What about immunotherapy? In Australia, you can access immunotherapy for head and neck cancer. And the current rule is if you've had progression of your cancer despite treatment with conventional chemotherapy in the last 6 months. But we're running trials where I work on what's called induction immunotherapy. So you give someone immunotherapy, then they have surgery, then you have immunotherapy plus or minus radiotherapy afterwards. And, from a biologic perspective, that's actually a much better way to use the drug, because immunotherapy, think of it like taking off the handbrake. So your cancer applies a handbrake to your immune system and says, don't look at me, ignore me, I need to grow. That's how an immunotherapy works, by uncovering the tumor to your immune system. Your immune system will be killing off cancer cells in all of us every day. That's what it does, which is why immune suppression is a risk for cancer in itself. Immunotherapy basically is like turning up the dial on your immune system. It allows your body to detect cancers, and probably the best way for it to work is if you have it before surgery. So your immune system gets a chance to look at the cancer and say, these are the signs on it. It's got, we can't live through COVID without hearing about antigen and antibody. It will generate antibodies to the particular tumor. And then with something like surgery, you remove 99% of the tumor. So your immune system has a lot less left to deal with. So biologically, induction immunotherapy actually is a better way to use immunotherapy than the current indication, which is if, we've thrown every stone we have at the tumor and there's still some left behind. Despite that, I've seen people cured with immunotherapy who I would have thought it's, there's really no other alternative, but it doesn't work for everyone, unfortunately. And at the moment, the only way we can find out is actually to try. Why not for everyone? And I talked about this before. This is the list of the 10 most expensive drugs in Australia. Number 2 and number 3 are pembrolizumab and nivolumab. They're both immunotherapy agents. They cost between them nearly $1 billion a year. That is a lot of very high volume surgeons working in a lot of very high volume hospitals. That's per year too. That's not forever. So, I'm not knocking it. That's kind of the way the system works, is that drug companies make drugs that then become very successful, and then they feel like they need to make back their development cost. So these drugs, are literally $4,000 or $5,000 a dose every 3 weeks for years, and they cost cents to make. So the profit margin, once you've actually developed the drugs, is extremely high. That's the system we live in, but they are very expensive drugs, and that's why they're not splashed around left, right, and center. And I think I might just pause there very briefly and see if anyone has any questions before we move on to the next section.
I have nasopharyngeal, so up at the
Back of your nose.
Yeah, back in the base of the brain by the pituitary gland. So would this all still be similar?
Oral cavity cancer, nasopharyngeal cancer is usually SCC. It's quite uncommon in Australia and New Zealand. It's much more common, as you're probably aware, in Southeast Asia due to Epstein-Barr virus. A lot of the principles are the same. The direct treatment application is probably not the same. Does that make sense? So
they say that it's non-curable and non-operable because of where it's situated. So I have had the radiation.
Yeah. So look, I guess it's very hard to know, I suppose, exactly about your clinical situation, but immunotherapy is something that probably would be very much worth trying if you're in that scenario now with something like a nasopharyngeal cancer, particularly if someone's told you it's not curable, because those are some of the people that I have seen for oral cavity SCC, literally, are very much in that scenario. And it's always a very pleasant shock to see them 2 or 3 years down the track walking into the clinic with absolutely no evidence of malignancy. But that doesn't mean it will necessarily work for an individual. They're all very promising anecdotes.
Okay.
Sorry, I was just going to ask a question if I can. But in terms of what do you see as some of the trending differences between how surgeons are treating patients in Australia versus New Zealand? Do you think there's a difference?
I guess yes and no, but not really. I know a lot of New Zealand surgeons. They have a very similar background to us, very similar training. I know the healthcare system is slightly different, but not really different. Some of the stuff I hear about how long people have to wait for cancer treatment in even cities like Auckland shocks me. And I think there's some bad politics going on, without getting myself into a huge amount of trouble. Internal politics that seems to not have patients' best interests at heart. But in general, the quality of the surgery, I think, is probably as good. Subject to the same problems that we suffer.
Yeah.
That you have a geographically dispersed population talking about a rare disease.
Yeah, lots of remote areas.
Lots of remote areas.
Yeah.
If you were going to design it, you probably almost need one head and neck center in the North Island and one in the South Island, but you've probably got about 3 or 4 in each.
Martin, what about the targeted drugs, the new drugs that are very specific to the DNA? What do you see with them in the future?
That's a really good question. The answer is quite complicated. So targeted therapy basically means identifying a genetic mutation that a patient has through whole genomic sequencing of that person or their particular tumor, and then giving them a drug that specifically applies to that. I think the difficulty with that is it's been around for a long time and really there's a couple of exceptions where it works really well. There's a certain type of leukemia, for example, where it works really, is very effective. But
So who's going to stay home by himself?
if you're in the US, for example, you would get your tumor genomically sequenced, pretty much everyone gets it done. And talking to medical oncologists in the US, they said that it almost makes no difference whatsoever. And the problem with cancer is it's got so many pathways that, it will just bypass. If you pick one mutation that you decide to treat with a targeted therapy, it actually has to be a critical mutation that keeps the tumor alive. Otherwise, it just finds a different way to get around it, which is why immunotherapy probably works, is that it's not targeted to an individual mutation on the tumor, it's targeted to every mutation. And the more mutations a cancer has, the more susceptible it is to immunotherapy. So there's something called a tumor mutational burden. There's a graph of it that you can see. It kind of goes like this. If you have a very low mutation tumor, something like pancreatic cancer, immunotherapy is not particularly effective. A very high mutation tumor, for example, a melanoma that's got a lot of sun, gets a lot of mutations, it's very susceptible to immunotherapy. And head and neck cancer in general is about halfway along the line. And the other treatments that are quite more effective for head and neck cancer ignore the pathways. So surgery has got nothing to do with pathways, does it? It's about cutting lumps out, and radiotherapy is about the same. It's just burning things. It's going to sound terrible, but that's pretty much what it is. And improvements in survival that we've got over the last, probably 30 or 40 years have been because we've got better at doing those things, not because their actual mode of efficacy is different. Does that make sense? Sorry, it's a bit confusing. I mean, targeting therapy is very exciting, but its current role in head and neck cancer is probably pretty limited, other than in a research facility group. There is a trial at one of the hospitals in Brisbane specifically on that. So really patients who have no other treatment option, if they can get a specimen of their tumor, and then you basically go into a basket trial where they'll find a drug that affects the mutation that you're on and then try targeted therapy. So those things are ongoing, and, but I'm probably a little bit less hopeful about them than I am about integrating something like immunotherapy into head and neck cancer. What about questions? Oh, we've done questions on oral cancer, so I'll move on to reconstructive surgery. So again, general overview, some of my research and what's kind of new in therapy. So oral cancer or mouth cancer, which is not all I treat, but is certainly a significant part of it. Reconstruction is needed for almost all oral cancers, and that's because surgery is part of almost all oral cancers. This is a tongue cancer, and the simplest form of reconstruction basically is just cut it out and stitch it up. Now, that's very basic, but for something of that size, that person's residual tongue will work very effectively. They can speak and eat and drink, and there's no donor site morbidity, which means no transplant or harvest from elsewhere in your body to think about. Things get more complicated when we start moving stuff around. So this is someone with a very widespread, this is not the cancer, this is actually after a skin graft has been placed on it. We're all Caucasians that we can currently see on the screen anyway that live in sunny climates. So skin grafts for skin cancers on the outside of your body are extremely common. You can do them in the mouth as well, suitable for really widespread but superficial tumors. This is something called a buccinator flap, which is a part of the cheek rotated up to fill in a hole in the top of your mouth that you might have if you have something called a maxillectomy. And really what we often do in reconstructive surgery is move up and down degrees of severity, so something small doesn't need something complicated, but something very big does need something complicated. So you move up and down these degrees of severity, and the further you go up the degree of severity, the greater what we call the donor site morbidity. So if we have to take this from somewhere to move it somewhere else, often your head and your neck has priority over other parts of your body because it's so important really for all of your functions, your activities of daily living, to use a medical term. So people are quite willing to have some part of their body harvested to reconstruct their head and neck, because your head and neck is really, what you face the world with. This is something more significant. A patient who's had a maxillectomy, so we're looking into their mouth, and you can see they've really lost more than half of their top jaw. On the right-hand side, half of their teeth, that's half of the soft palate. I don't know if my arrow is coming up, but that's their uvula just there, the dangly bit at the back of your throat. And that person had a transplant of their hip bone with muscle into the midface to replace the top jaw, fill in the soft palate, and then dental implants put into that hip bone and teeth on top. So that's a more complicated, more sophisticated reconstruction for someone who's lost half of their top jaw. But when you start doing that, there's a price to pay, which means a donor site morbidity. And when I talk about, I literally had this conversation with a person today who needs a lower jaw reconstruction. And I said, you've got really 4 options about where we harvest that bone from: your lower leg, your hip, your shoulder blade, your wrist. And probably an analogy that I like to use, and hopefully it makes sense, is you can choose which bank account it comes out of, but you can't choose the price. So all of those donor sites will have a price, and my aim, I suppose, as a reconstructive surgeon is to have lots of options. So to say to people, what do you like doing? What are your things that you enjoy? If you like running, we shouldn't harvest that graft from your lower leg. If you like playing tennis, probably your shoulder blade's not the best choice. Or if you like swimming. So try and personalize those options for people, rather than say, here's a prescription, this is what I do. This, in some cases you need to do that because there's only one option that will actually work. But the aim is for people who have options to give them different options. Here are a few very frequently asked questions. Can I have my jaw 3D printed? The answer to that is yes, but not in your own tissue. So not in human tissue. It can be printed in plastic, which is not much use to you. It can be printed in titanium, which we could actually put in, but titanium, like all metals, will fail in people over a long period of time. So for people with a reasonable life expectancy, that's not a good option. We do use 3D printing quite a bit, and I apologize in advance. I think the only slide with any blood in it is coming up very shortly. Another question I get is, can my relative give me their bone or soft tissue? And the answer to that is almost always no. If you're a twin, you can, because you have the same DNA. But if you're not a twin and we transplant a bone or a piece of skin or something into you, then your body will reject it, unless we give you immune suppression. And then immune suppression and cancer, as we already talked about, are not good friends. We do use 3D printing and something called virtual surgical planning all the time now. In fact, every patient who has a jaw reconstruction will have some version of this, where we import CT data. You can see there's someone's skull. That's the fibula or lower leg bone shaped to look like a jaw. And these are the kind of steps in 3D printing and virtual surgical planning. Image acquisition, which means that CT data, you transfer it, you remove all the stuff you don't want, you plan it, and we do that with biomedical engineers. We review it, and then you can manufacture custom plates and screws that are specific for that person and their situation. And usually that's what this looks like. So you decide this is the bit of the jaw we want to take out. The company, or if you have a 3D printer, you provide you with what's called a cutting guide. So that goes on, you bolt it onto the jaw, slice between the 2 lines. This plate is pre-fashioned or fabricated for the patient, so it fits exactly. And there's lots of advantages. It's easy to visualize. Surgeons are tactile and visual people as a general rule, so we can see things. You can the plates fit exactly. They don't need to be manipulated. It's very accurate. You can get people's teeth to line up almost perfectly. You can do a better job of cutting the graphs up. The main disadvantage really is you can't change the plan on the day. Once the plan is set, the plan is the plan. So it's very difficult to alter it once you've made it, but it's really become quite routine. I know I don't want to keep people going. We've still got a bit on prosthetics to do. Is there any questions on that really very brief overview?
Just a quick question. With the 3D printing, is that available both in public or private, or is there a difference?
That's a good question. That depends a little bit on your healthcare system and your hospital. And I can only really tell you about what happens in Australia. So in Australia, for example, if you have private health insurance, you go to a private hospital, you can have all of that stuff on that picture paid for by your private health insurance without paying anything out of pocket. If you go to and I work, 80-90% in the public hospital, about 10% in a private hospital. If you go to a public hospital in Brisbane, the difference in cost, that whole suite of technology would cost the health fund somewhere between $10,000 and $12,000. If we pre-bend this plate, just the blue one, they cost about $2,000. So what happens in the public hospital is we're very fortunate. We have a 3D printer, biomedical engineer, and a kind of pretty keen interest in this sort of stuff. So if you come to the public hospital, we will 3D print your jaw, get one of those plates, bend them, the stock plate, so it fits exactly. So effectively you get pretty much the same outcome for about a fifth of the cost. And, if I go to the director of surgery in my hospital and say, this person has a very specific problem, they're really going to benefit from this technology, they'll probably say yes. But that's, I guess, because he knows I'm generally fiscally responsible, if that makes any sense.
Yeah, it does.
And how long after surgery is it possible to do this type of reconstruction?
Well, it usually gets done at the same time the cancer comes out,
yeah.
but it's possible to do it at any stage. This person here, to give you a bit of his story, he had a plate, an obturator, which is a modified denture in his top jaw. He worked as a bus driver. He'd had it for, I think, 15 years and been told that nothing could be done. And he was sick of kids laughing at him when he got them on and off the bus because he couldn't speak properly. So he had that surgery 15 years after his cancer was taken out.
And of course, it makes a difference whether you've had radiotherapy or not.
It does, but it doesn't make it, it's not impossible. Radiotherapy makes some things more challenging, but it doesn't mean that, and often the advantage of these grafts, particularly if you have it after radiotherapy, is they come from a part of your body that's not irradiated. So radiotherapy is very specific to the site that it goes to. If you have radiotherapy to your hand, it doesn't affect any other part of your body. So if you have radiotherapy to your head and neck and you get a graft from your leg, the graft has never had radiotherapy. So it wants to heal just fine. It's really where it goes into that can be more challenging. So, I treat a lot of people for something called osteoradionecrosis, which is bone necrosis secondary to radiotherapy. So they've all had radiotherapy and we do these grafts. Literally the patient I was talking to today has that problem, having that surgery on Monday. So radiotherapy is not a preclusion to secondary reconstructive surgery. In fact, a lot of the time it's actually an indication. But it does make it, more challenging. And I'm going to talk finally on facial prosthetics. And I know that New Zealand actually has they've probably got several very good facial prosthetists, but I know there's a very good one in Hamilton, who I've been in touch with for many years and seen a lot of their work. It's quite amazing. So that will give you some, in fact, they're better than that. We've just lost both of ours. So we have no one and they've got one very good one. So I might try and pinch him.
What's his name? What's his name?
I honestly don't know, but there's probably only one facial prosthetist in Hamilton.
All right.
in
Yeah.
Waikato.
We'll block his passport.
Yeah, good idea. I won't do that. I'd feel awful. So don't worry, I was joking. So I'm going to talk a little bit about kind of modified dental implants for intraoral and extraoral prosthetics. One of the sort of newer things we use is zygomatic implants. Is a very patient-focused story, but hopefully it gives you some indication of what can be achieved. So this is I think I treated this person about 9 years ago. So this is a very old 3D printer. You can see the little kind of hairs on it. They didn't turn out quite as well. But he had lost really the whole central part of his top jaw from a carcinoma of his, not a carcinoma, sorry, a sarcoma actually of his septum. So he had a big hole between his mouth and his nose, a really big hole. Had no teeth, as you can probably see. That's a model of his top jaw, so couldn't hold his obturator in. And basically he was holding his denture in with his tongue when he tried to talk, which makes it very hard to talk and eat and drink. And his ENT surgeon actually sent him to me and said, is there anything you can do? And I said, well, normally for that sort of person, we would do one of those grafts from elsewhere in your body. We would seal off your mouth from your nose, put bone in there, put implants into that bone, and, get your teeth that way. But that's a big operation, multiple steps. This person had already had bilateral below knee amputation, so he's in a wheelchair, which makes that quite complicated. He's quite elderly and not particularly well. So these implants that hopefully you can see my arrow, but they go all the way from his mouth up to his cheekbone. They're actually 55 millimeters long and embed into your zygomas. You can't see them from the outside. They're literally in the mouth. And you can see where they come down into the mouth, and his prosthodontist has made him a very nice denture that effectively clips onto that thing. So, for someone like him, it was really life-changing. That's a big denture. He went from having to hold that in his mouth with his tongue every time he talked, ate, or drank to, being able to chew food. We actually put a couple of implants in his lower jaw as well, which also gave him a very stable lower denture. And he said he went to the pub and showed his friends and celebrated with steak and everyone buying him beer. So it was really a very gratifying story. I think he only lived for 3 or 4 years after this operation, and not from his cancer, died from some unrelated cause. But, that was a procedure that he was in hospital for a day. So a very, really life-changing for him, even if it was only for the last 3 years of his life, made a really, really big difference. So prosthetics are, a real combination, I think, of art and science. Facial prosthetics or extraoral prosthetics are really good for areas that are impossible to accurately reconstruct. So there are some things that we just, no matter how much we put stitches in or do cuts, we can't make it look like the original. Your nose is a good example of that. Your ear, your eye, or a fingertip, are things that are frequently reconstructed with prosthetics because you can just make it look like it actually should look. They're almost always silicon based, but they can be hard acrylic. They can be spectacle retained or glue on, but osseointegrated implants or implants that go into the bone and anchor these prostheses are a much more reliable way of securing them. They're little dental implants, a modified version, because dental implants usually go into your jaw. They're, anywhere between 6 and 15 millimeters long. These ones that go into your extraoral bone are frequently about 3 or 4 millimeters in depth. So not particularly big, but they fuse to the bone. And then there's a little post that comes through the skin, and that's used to anchor the prosthesis. This is a kind of good example. This lady lost her eye to a skin cancer, had a socket that didn't look particularly attractive. And, one option for her is a patch, of course. Another option is to wear glasses with a spectacle retained prosthesis. But she's had 2 implants put there into the outer side of her eye socket, joined up with a little bar, and a facial prosthesis that's carved in wax, has an eyeball that's included within it, and then replicated in silicone that literally clips onto there. Not perfect, probably mainly because of the skin match color, but certainly significantly better than that. And for her, a much more satisfying outcome than a prosthesis.
Yeah.
This is someone who lost his ear to a melanoma. He was a school teacher, you know, again, really very self-conscious about kids teasing him, grew his hair long, but it kind of just looked strange. He's had 2 implants put into his mastoid bone. So if you tap behind your ear, there's a very hard bone there called your mastoid, which is a common site for putting these implants in. And that's what his prosthetic ear looks like. So other than the fact that it doesn't change color, you know, you actually have to look closely to tell that it's a false ear or a prosthetic ear. Whereas if we tried to make that out of skin and cartilage, you know, they frequently just look like rubbish. So that's actually a much better outcome. Those things are not without problems though. And this is the same photo. You can see the kind of crusting around the implant. So it's not actually normal in your body to have anything that goes through your skin and into your bone. So that interface between the external environment and your bone is very specific. In fact, if you think about it, the only place in your body that occurs is your teeth. And there's a very specialized tissue environment around your teeth that keeps it healthy, and you have to keep it clean, don't you, every day, sometimes multiple times a day, to prevent that causing issues. So these people have to clean these things literally once or twice a day. They're quite prone to kind of chronic infection. So one of the projects that, or a few of the things we're doing, so for this patient, to try and match his ear, what used to happen is the prosthetist would take a photo of him. They literally carve that ear out of wax, and then wait till they try and got it perfect, multiple visits backwards and forwards to check the ear against the other ear. Then eventually you put the wax in a plaster cast and make a mold, and then you can make the ear out of it. But if you have to break the mold really when you get the ear out, so you get to make one at a time. So what we do now for people like this is we can do a digital surface scan or an optical scan of his contralateral ear. So there's various optical scanners that will generate a 3D version of your other ear. And you've probably all mirrored photos on your phone. You can do the same with the 3D file, where you basically sorry, I'm trying to get my hand, you just flip it. So your left ear becomes your right ear. You can print that quite readily in plastic or any other material. So it just eliminates the whole step of a technician having to carve their ear. So you can get an exact replica of their contralateral ear, really, within hours, rather than days and days of carving, and it's a one-off. So if you lose it, you just hit print on the computer and it comes out again. Someone with a nose, for example, you might say, well, you've only got one nose, and that's true, but you can scan it before the surgery. And if they've got a cancer on their nose, you can take the cancer off digitally. So you can give them back their same nose. Not everyone wants their same nose back. There's plenty of people come asking for Brad Pitt's nose or someone else's nose, but you can literally have your same features replicated. So that's quite a novel, a neat little technical trick. 3D printing in silicon is probably coming, although it's quite tricky just because of the material. But one of the projects we're working on with the Biofabrication Institute is to get around this problem of the posts coming through the skin. And we designed a subcutaneous magnet system, basically where you bolt magnets onto the body, cover it up with, sorry, I'm still trying to get my hands right, cover it up with skin. So there's nothing coming through the skin, but the magnets are in there underneath. And then they're found by the ear, which has corresponding magnets. So basically you just bring it closer, they attract, hold it on. With no transcutaneous posts. That will work for an ear, an eye, a nose. One of the technical tricks is you can't just put a magnet in someone, because as they break down, they release quite toxic chemicals. So they have to be laser welded inside a titanium housing to make them safe, like a pacemaker, for example. The other trick really is controlling the external force, because if the magnets are too strong, you can imagine it squashes the skin in between. If they're too weak, the prosthesis falls off. So, we're just trying to strike a balance between those two things. And I think we're probably getting close to an hour. I'm certainly happy to take any questions, but my voice is literally about to fail as well. So that timing is probably pretty good.
Anyone got any final questions for Martin?
About any of the topics. It doesn't just have to be on the prostheses.
I mean, that's just the sheer amount of knowledge and that you've gained in your, is very young. Martin.
I think the years have been kind. Again, I spend a lot of time inside a room, so I don't see much sun, unfortunately.
It blows me away, absolutely blows me away. From someone, I had tonsil cancer, and I had an absolutely awesome surgeon. I didn't have radiation. He was also very good, gave me all the stats. Oncologist was very good, gave me all the stats. Said you could go this way, you could go this way. Gave me all the information, and I made the decision to be clinically managed. Worked out really good for me. I'm on 4 years, and I think it's just having, as you say, someone to give you all the information so that you can make that choice. Yeah. You do know that there's an issue with just educating people to take ownership of their own journey is a very hard thing to do. I live in Australia now, and I've been in the health system. I work in the health system, and I've worked in the health system since 2005 in New Zealand and in Australia. But just getting people to just undertake that information, own your own cancer journey or whatever journey that you're on is a real difficult. It's a real challenge. So how do you turn around and get this information out to them? Obviously, this webinar is a great one, Diana, because we can get it out to them. It's really just encouraging people just to learn something. You'll be fascinated by what you can learn and therefore how it can help you navigate your journey. It would be so awesome. I think you can ring 0800 head and neck cancer and then talk to someone, and they turn around and can help you navigate your whole journey, because it's so complicated, as we all know, really complicated.
It is very complicated, and I think it's also very hard because not everyone wants the same degree of information. Some of that's age-based. I offer people as much information as I can. Obviously I don't know everything. I wish I did, but you can give people what you do know, but not everyone actually wants to know it.
That's right.
And a lot of people don't ask good questions. I've had relatives and friends who have cancer, and I say, you talk to them and they just don't ask the right questions, and no matter how, and most clinicians are happy to tell you, but I hope, I think, but it's very challenging. And the Cancer Council in Australia, and I'm sure there's a New Zealand equivalent, try and help with those things, but it's such a diverse range of problems.